Anyway, we're talking about biomechanics of the spine. It's a very difficult and a tough topic. So let's talk about some basic things which you'll already come across. First thing in biomechanics you have to understand is the functional spinal unit. So functional spinal unit is the most basic physiological unit, and it is made up of one vertebra above, one vertebra below, and the intervertebral disc in the middle. And 70% of the weight goes through the anterior column, which is through the body and the disc, and 30% through the posterior, through the facet joints. Yeah. So it's a posterior, so superior facet, pars interarticularis, and the inferior facet take the 30% of the load. Then you have spinous processes and various areas where muscles are attached. That is for giving a balance, tension, and things like that. We will discuss about it in due course. So now we must know that spine is a mobile structure. See the chats, what are they? Spine is a mobile structure, and it has 6 degrees of freedom. Now the degrees of freedom is flexion extension, lateral bending, and axial rotation. Now you can see all the spinal column, they have different characteristics. Cervical spine has more of axial rotation possible and flexion extension. Lateral bending is also equally possible, but axial rotation will be more possible in the upper cervical spine than the subaxial spine. While in thoracic spine, in the upper thoracic spine, lateral bending is limited, so is flexion extension. So because you are in the rigid portion of the thoracic cavity, which is T1 to T5 or T7, while the lower thoracic spine has more flexion extension, lateral bending, axial rotation is possible all throughout the cervical column. Now, lumbar spine is more prone to flexion extension, lateral bending, but no axial rotation. So if you have forcible axial rotation in the lumbar spine, you end up fracturing the posterior elements. Okay. If you cannot understand, you can either put it in a chat box. I'll be checking the chat box regularly, or if you want me to come back to any of these slides in the future, we can do it. Yeah, maybe next. Yeah, now, yeah, okay. The functional spinal unit, as I said, is the most physiological unit. Now you must understand this whites and Punjabis, the concept. Will they be able to say this? Yeah, move it over. Whites and so this particular graph on the right side of your screen, where my arrow is, it talks about neutral zone and the elastic zone. Now that concept is fairly basic. You must understand that there is some movement of the spine that will take place where the spinal elements or the capsules and ligaments and tendons are lax, and this is low resistance motion. So this is called motion in neutral zone. Usually this is painless, and this neutral zone movement is important for implants, biomechanical testing, and things like that when we are designing implants or designing disc replacements. Elastic zone is the zone where the ligaments, fascias, and tendons stretch, and hence more load is required in the elastic zone for causing the same movement. So in neutral zone, you require less movement. In elastic zone, you require more movement. And if the spine moves in the elastic zone, towards the end of elastic zone, you'll find that there may be a little more pain and stretch feeling in the patient. Yeah, next. Maybe I'll control myself rather than calling next. Normal disc anatomy, you can see that this comprises of a vertebral body and the disc. The disc is made of annulus and nucleus. Nucleus is nucleus is isotropic. That would mean that it transmits pressure equally in all directions. Anisotropic is the Pressure transmission may not be as equal in all direction, and hence that's an importance of weight transmission and stability. Annulus provides stability to the disc, while nucleus acts as a shock absorber. So hence, like so here. So the nucleus material is viscous, and the viscosity of this material changes with age, and hence when we come on to disc degeneration, you'll find that things may differ with time. Now we talk about disc degeneration. Now we can see the same thing when you have a load which is transmitted on the spine. The axial load is there. The disc is good height, good turgor, and it behaves like isotropic. When we become degenerate, there is the same load will cause abnormal mobility, and this abnormal mobility will now cause increase in load that is transmitted through the posterior elements, then increase wear and tear of the posterior elements. Now this happens with age. This is normal process with aging. However, it can start early in patients who have degenerate discs or tendency towards degenerate discs. Now, disc degeneration etiology is definitely genetic in origin. It can have age-related accumulation of microtrauma. That means with time, all of us will degenerate our discs. Now, again, genetic constitution will make some of us to degenerate faster, some of us to degenerate slower. Again, there are nutritional changes. Now, nutritional changes can happen. Most common reason for reduction in nutrition of the disc is smoking. Not a problem in Pakistan, I guess, but it's a definite problem in the West. Now, disc degeneration features. What happens in disc degeneration? The disc loses height. As it loses height, there is increase in sagittal plane instability, and this sagittal plane instability will cause wear and tear of the facet joints, increase in facet joint size. Also, there is decrease intersegmental muscular force, and hence the treatment, physiotherapy does work in patients with early disc degeneration. The only problem is a majority of the patients whom you treat with or whom I treat as well do not follow instructions of physiotherapy, and hence they say physiotherapy doesn't work, because physiotherapy is like dieting. It never works in 1 or 2 exercises. You have to do it about 20 minutes a day, at least for 6 to 8 weeks, then only it will work, because intersegmental muscles are not very easy to train. They are the most difficult to train. Walking is not equal to physiotherapy of spine. That's what the patients have to be told. And obesity definitely increases the load on the spine, and hence the intersegmental mobility will be more. Now we will talk about Kirkcaldy-Willis. If you're taking exam, or if you're going to become a spine fellow or anything like that, or just, you must know the Kirkcaldy-Willis cascade. So disc dysfunction may cause disc bulges or disc herniation. As a result, I talked about instability as well. This is abnormal motion. Sometimes this abnormal motion may give rise to spondylolisthesis. And in the stabilization phase, it stabilizes by osteophyte formation and reduction of disc height. It will lead to canal stenosis and lateral canal stenosis. We are talking about disc degeneration. How do we assess disc degeneration? The best tool for assessing disc degeneration is radiology, of which the radiology MRI scan is the most appropriate tool. And Fuhrmann's classification was described in 1990s. Fuhrmann's German radiologist, and he divided them into 5 groups. So basically 1 and 2 are healthy discs, 3 and 4 are early disc degeneration. Phase 5 is collapsed disc, which is in the Kirkcaldy-Willis the cascade. It is the last stage, which is equal to spinal stenosis and again, in 2007, Griffith modified it for a better understanding, but basically still it remains the same. He subdivided the Fuhrman 3 and 4 further, and the next slide will take you through how he divided it. So we can see that the normal disc height or normal disc is the modified Fuhrman or Griffiths class 1. Early disc degeneration can be Griffiths 2 and 3. And then you can see that the Fuhrman 3 and 4 are again hypointense in the, so that means the signal characteristics is low, but the disc height is normal. So hence this may have some treatment connotations. So patients who have normal disc height and who have early disc degeneration with annular tear may do well with some of these minimally invasive techniques like radio frequency treatment and laser treatment, if you believe in some. But I think if you choose the patients well, so if you're looking at the Griffiths 4 and 5, these kind of things work very well. Griffiths 3, 6, and 7, where there is reduction of height up to 30% or 30 to 60%. So physical reinstating of the disc, so disc height, maybe interspinous devices work very well. When you come up to Fuhrman 5, or which is Griffiths 7 or 8, where is major loss of disc height, usually spinal fusion works well in them. Now again, we will talk about the Griffiths classification, or again Fuhrman's. You can see the grade 1 and 2 are normal discs. Grade 3 and 4 have good disc height, but signal is lost. Grade 5 also the disc height slightly reduces, disc bulge happens. Grade 6 and 7, you start losing height. Grade 8 is total loss of height and degeneration. Now, disc degeneration also affects the end plates. Now, MODIC was the person who described end plate changes in degenerate discs. And again, we can divide them into MODIC 1, 2, and 3. This is early stage is where the disc has got good height and there is increased signal in the adjoining bone. So it's bone edema, bone inflammation. So again, you can see high signal in T2, low in T1. This is MODIC 1. Now, then over a period of time, as if the disc degeneration continues, then you can get the end plates, they get converted to yellow or fatty marrow. And yellow and fatty marrow, because it's fat, it is high in both T1 and T2. And over a period of time, you can get subchondral sclerosis. The concept is same. If you look at the knee arthritis, also it is the same thing. Initially, it's bony edema, followed by fatty replacement, followed by subchondral sclerosis and subchondral cysts. Again, similar changes take place when you come to MODIC 2 and 3 changes. That means there is some element of chronicity. Maybe fusion works better. And MODIC 1 is probably reversible and non-fusion technology works better. Now let's look at intradiscal pressure. Now, when is the intradiscal pressure maximum? You can see that forward bending, sitting increases the intradiscal pressure. This is an old slide from Alf Nackemson's study, and you can see that the standing position, which is here, that standing and forward bending or sitting and forward bending is the one that increases the disc pressure more. Now let's go on to, now we talked about spinal or disc degeneration. We'll talk about spine instability. Now, White and Punjabi were the first ones to have described the spinal instability, and they said that loss of ability of the spine under physiologic loads to be able to, or they cause abnormal displacement leading to additional neural deficit, no major deformity, or incapacitating pain is equal to spinal instability. So that means there is an importance here that under physiologic loads, if there is a loss of ability of the spine to maintain or cause increased displacement, then it is equal to spinal instability. And again, this definition was simplified by AAOS, and they said abnormal response to applied load characterized by movement in the motion segment beyond normal constraints. So this is far more simple. Normally, when we have a load applied to the spine, there will be some intersegmental movement. But if the intersegmental movement increases, then we call it spinal instability. And this spinal instability can be documented or studied by flexion extension views. Now, POSNER's criteria, POSNER described it in 1983. There have been few modifications, but roughly you can remember that any movement which is between 3 and 4 millimeters between L1 to L5 is abnormal. Up to 3 millimeters between 2 and 3 at L5 S1 level is abnormal. Angular movement greater than 8 degrees in flexion is abnormal between L1 to L5, while more than 14 is abnormal. You will find various figures. You can follow whatever your department follows. Now again, the POSNER's criteria is specific in 90%, and there is a positive predictive value. That means if there is instability, then it can be picked up positively by a lot of people. So if you go and measure 90% of them, and then it is a reason for going for further investigations if there is increasing translational instability or angular instability. Now, whites and Punjabis, now this instability is more of a criteria described by white and Punjabi, more for fractures. Now, when we talk about this, has actually gone out of fashion. When I was training, white and Punjabi's classification was used far more to describe what was clinically unstable. And again, if you have anterior loss of height greater than 25 millimeters, were given 2 points. Disruption of posterior elements is 2 points. Sagittal translation of any fracture greater than 3.5 millimeter or 20% was 2 points. Then rotation. Again, all this is the basic concept that has gone into making any of the further fracture classification, whether maybe it Ferguson-Allen or the present AO classification or the TLEX. They have basically used this basic criteria described by White and Punjabi in 1980s. Again, going back to step back, what is the treatment for a degenerate disc with instability? At present, the gold standard is still a spinal fusion, and the spinal fusion is by the help of pedicular screws and cages, and you can do PLIF, TLIF, ALIF, whichever way you want to go. PLIF is posterior lumbar interbody fusion, TLIF is transforaminal, ALIF is anterior. Okay, and in the cervical spine, it is ACDF. Uninstrumented fusion nowadays has less role to play. I think mostly in our areas also, even neurosurgeons have started instrumenting. Yeah, again, the success rate of clinical success rate of spinal fusion is about 45 to 85%. So that means still not the right answer, although we can get. So hence, if this was not the right answer, people thought about load sharing devices. Load sharing devices are, so again, the same analogy which we take in joint replacements, that is knee replacement versus knee fusion. Initial treatment for arthritic knee was a knee fusion, followed by joint replacement, same for hip. And the load sharing concept came in, and the idea of preserving intersegmental mobility, preserve stability. We had to have biocompatible implants, the implants that prevented migration and that prevented early or late bone fixation, or which had early and late good bone fixation and which prevented bone resorption. Again, the concept was similar. It was translocated from a joint replacement feature, but again, we have more the surrounding structures in the spinal column are much more delicate, and hence the joint replacement of the spinal column, artificial disc replacements, have to be very, very carefully designed. So again, then we go on from this instability to what is called as iatrogenic instability. That means you can develop, or we can provide instability to a patient from medical or surgical intervention. Again, as I was discussing with Sohail, again, there is a problem all over the world that a lot of orthopedic trainees and even maybe neurosurgical trainees who do not understand the concept of stability of the spinal column, in order to decompress, may remove more structures and cause iatrogenic instability. The iatrogenic instability then can lead to kyphus formation. It is most commonly seen in neurosurgically driven wide laminectomies of the cervical column with instrumentation causing kyphus. Then post-foraminotomy induced kyphus. Again, if you remove excess amount of facet joint, again, sometimes it can cause adjacent segment disease, and sometimes nowadays patients living longer after radiotherapy can end up in iatrogenic instability. Now this one shows on the left side, if you're looking at an anterior corpectomy, you can see that the anterior column, when you look at this, is a cube distribution described by, I think it was, if I forget the name, but anyway, I have a feeling that this was, I'll get his name. Anyway, he felt that if you're removing the bone in the anterior column, if you remove the bone in the far anterior column, then you render the spine unstable much more quicker. However, if you remove the bone in the posterior and middle column of the anterior part of the vertebral body, then you render it more stable for a longer time, and hence this same concept is used in tumor treatment when we talk about separation surgery. So separation surgery, we leave the shell intact and we remove the core of the tumor which is pressing onto the spinal cord, and hence an anterior column reconstruction may not be necessary. Now going on to the other picture here, we see that if you remove one single facet, or if you remove more than 30% of two facets, you can render a spine unstable. Now, in order to preserve this, if you have to do undercutting facetectomy, if you do not have microscope, then sometimes you can, Ed Benzel maybe. So you do not have microscope, then you have to remove the central structures. Yeah. Okay. Single level if done for discectomy. Let me. Does MODIC changes have any effect on management? I think I've covered this question, that if you have MODIC 1 changes, I'm just taking the questions on very quickly in the middle. The MODIC changes does have an effect. I just mentioned that if you have MODIC 1, then you can do changes. We can do things like good amount of physiotherapy, maybe radiofrequency treatment. MODIC 2 and 3, maybe more direct surgical procedures involving the disc. Then what should be the optimal level of fusion, vertebrae above and below the pathology for cervical thoracic? I think this question I'll take later. I think it depends on the pathology. There is no hard and fast rule. If you have a pathology that involves one level, you just fix one level above and one level below. If you have tumor or fractures, usually two up, two down. But there's no, then somebody is asked, what are the chances of spinal instability that can result from a single level lumbar laminectomy? Lumbar laminectomy, if done for discectomy, I have just covered. So if you're trying to do a discectomy or a laminectomy, if you remove more than 30% of two facets on both sides, or if you remove a single facet completely, this does happen when people are doing discectomy without using microscopes. So I think using loupes and microscope and good lighting is important to prevent iatrogenic instability. Now, this tube concept, which is popularized by Ed Benzel, but again, it came off from, this tells you the same thing, that if you remove the anterior portion of the vertebral body, then it makes the spine more, tendency for collapse is more. If you leave some of these, so this figure G talks to you about G and H, talks to you about separation surgery. That means if you leave the shell intact and you decancelize the bone from the posterior and middle part of the vertebral body and fix it from the back, then you probably still remain a stable construct there. Now, iatrogenic instability, again, it usually results in revision surgery, and it's very, very important. These patients present, what happened? Yeah, no, don't worry, don't worry. Yeah. So my research team is also with me. These guys are also very keen to learn at the same time. So again, we are talking about investigations. We need to do radiographs, CT and MRI. And then, as they rightly mentioned in the slides, that it funnels towards revision surgery. So we now move on to a different concept totally, is to talk about spinal curvature. Now, spinal curvature here is classic. Now, this picture gives you about the spinal curvature, which is talking about cervical lordosis, thoracic kyphus, lumbar lordosis, and sacrococcygeal kyphus. So in the AP plane, there should be no movements, there should be no curvature. If there is any curvature, it becomes scoliosis. Again, this is very important for stress distribution, for flexibility, shock absorption. Yeah, okay, move on to the next slide. Now, normal spinal curvature is roughly 20 to 40 degrees of cervical lordosis, 20 to 50 degrees of thoracic kyphus, and up to about 40 to 60 degrees of lumbar lordosis. These are acceptable values. Sacrum has a kyphus. Yeah. Now, measurements of cervical lordosis. The cervical lordosis can be C1, C2, definitely has. So if you want to measure the cervical lordosis, you measure the lower border of C1. So you can see here the one that goes through the tip of the spinous process, lower border, and then you go on to the lower border of C2, and the angle subtended is the C1, C2. It's called the atlantoaxial angle. Normally, it's about 25 degrees. Subaxial angle, which is from the C1 to C7, is subaxial angle that forms the rest of the cervical, and it may be between 15 to 20 degrees. So roughly 60%, 50 to 60% of the cervical lordosis is at C1, C2. Rest is in the subaxial spine. Thoracic kyphus can be measured into T5 to T12, which is roughly 30 degrees, or if you measure from T1 superior end plate to T2, T12, these are Cobb's angles, yeah, Cobb's angles. So Now, Cobb's angle does not necessarily have to be for scoliosis measurement only. He initially described it for scoliosis, which is, but anything which we take a line parallel to the end plate of one vertebra and line parallel to the end plate of the lower vertebra and the angle subtended is still called a Cobb's angle. But for ease of description, we call it thoracic kyphus angle, and the thoracic kyphus can be from T5 to T12 or T1 to T12. Yes, okay. Lumbar lordosis is classically between the superior end plate of L1 to superior end plate of L5, and I said it can be between 40 and 60 degrees. Now, again, some important figures to remember that 60 to 75% of the lumbar lordosis is at the L5S1 level. So this is very, very important when we are doing fusion. Now, when you are doing fusions at L4-5, L5S1 level, you should calculate what was the lumbar lordosis of this patient, and that can be worked out from the sagittal alignment equation, and we can work that out here. Okay, fine. Now next is sagittal. Now sagittal balance is different from sagittal alignment. Sagittal alignment just gives you what is the alignment of the vertebral column at any point of time. Normally, a sagittally aligned vertebral column will have the C7 vertebra right over the S1 vertebra, and the earlobe or the auditory meatus, the line going through the auditory meatus goes through the C1. So now this is the C7 gravity line, usually goes slightly anterior to T9, and it bisects the S1. The normal value, it can be about 28 millimeter anterior or 20 millimeters posterior to the posterior aspect of the S1 end plate. Okay, and sagittal balance is when there is no outside force acting on the spinal column. The muscle response of the trunk under sensory neural regulation is just enough to maintain an upright posture. Okay, so it is very important that sagittal alignment is different from sagittal balance. The sagittal balance can be achieved by using some external forces as well. Sometimes patients who have poorer sagittal alignment, your sagittal balance can be improved by the help of walking stick, and so the net moment of weight that passes through the spinal column is zero. Okay, now sagittal imbalance is when it can happen in low back pain. It can result in low back pain, difficulty in walking, difficulty in maintaining. That is when the spinal curvature or the deformity increases and induces a non-zero moment. That means your normal muscles of the spinal column are not able to produce sagittal balance, then hence you have an imbalance, and that could be painful, and usually patients with sagittal imbalance will require surgical intervention or therapeutic support. Now measurements, this is a complex slide. This tells you about all the various methods of looking at it, but I think I've divided them for easy understanding. Now, sacral slope is one of the very important parameters for sagittal balance. It is the inclination of the end plate to the horizontal line. We can see that here. Then we can have, you want to just hold on for 1 second. You want to put the dial on that and then listen to it quietly on the. Then the pelvic tilt is defined as the angle subtended by the vertical line here and by a line which is the center of the femoral head and the center of the sacrum. Now, this tells us the relationship of the sacrum with respect to the femoral head. Now, that's a very important, uh, factor. So, if the tilt is reduced, that would mean that the patient's having compensation. Tilt is, yeah, okay. So, now pelvic incidence is actually defined at the time of birth, or maybe defined when you become an adolescent, and it's a factor that remains constant after you achieve full maturity. And now this is defined as an angle that is subtended by the lines drawn from the femoral head to the midpoint of the sacral end plate, and the line perpendicular to the sacral end plate. Now, this is a constant. Now, the usual formula is the pelvic incidence equal to pelvic tilt plus sacral slope. Yeah, okay, so that's how, and the lumbar lordosis is usually a derivative of this. Okay, now C1, now we can see that C7 alignment, if we talk about sagittal vertical alignment, normally the vertical line should pass through the S1 corner. An acceptable limit is about 5 centimeters anterior from the tip here, or 2 centimeters posterior. And it changes with age as well. It's a very complex, but as residents, you must realize that C7 plumb line in the lateral view must pass through the end plate or within about 7 centimeters of this point. Okay. Now, T1 to T9 spinopelvic inclination, I don't do it. Normally, it's easier for me to get the sagittal vertical axis, but T1 to T9, you can see the point here and the point from the femoral head. And this angle normally is 7.58 or 8 degrees. And this is more like a research tool than an easy tool for remembering. Now, what happens in real life is this is a patient with a reduced sacral slope, and then you can see that these are the conditions. Now, if you have fractures, if you have fusion with inadequate lordosis, or if you have muscle atrophy or muscle disorders, then you can find that the patients may stoop forward in order to compensate. They will verticalize their sacrum, so the pelvic tilt reduces. Pelvic incidence, as I said, never changes. And so if the pelvic tilt reduces, the sacral slope or pelvic inclination increases, the sacral slope will reduce. So the formula is like this. So sacrum becomes horizontal. When the sacrum becomes horizontal, you have to use a lot of forces in your lumbar spine in order to stand erect. And sometimes if the compensation is not enough, you may flex your body at the hip and the knee. So that would mean that the patient is compensated, but it's a very painful condition. And you may have to re-achieve this by correcting the lumbar spine itself. Now, you can have a condition where in osteoarthritic hips and knees, that is here, the sacral slope is more. However, the lumbar lordosis, in order to stand erect, the patient increases the lordosis. And that is also a painful condition because that increases accentuates the forces that go through the facet joints. And usually the correction has to be hip arthritis, on correction of the hip arthritis or knee arthritis. Hence, I think it is very, very important to work out by these two slides. I can take it on next time as well, because this is a difficult concept to understand. You should be able to work out where the sagittal imbalance of the patient is coming from. Is it from the lumbar loss of lumbar lordosis, or is it due to the hip arthritis or hip or knee arthritis? Next slide is talking about patients who get disc narrowing. More common is osteoporotic fractures. When we get osteoporotic fractures, we get thoracic kyphus, And in order to correct the rebalance ourselves, we may have to verticalize our sacrum. So the sacral slope reduces and pelvic tilt increases. Again, a painful condition. And as a result, and once if the thoracic or the thoracic fractures continue to deform the spinal column, then the patient may compensate by flexing the hip and the knee. Again, the sagittal balance in the osteoporotic patients, I just talked to you about it, that increased kyphus can cause patients to have increased lordosis, then or verticalize the pelvis and flex the hip and the knee. You see that very common in, I think I'm coming to the end of the talk here, as now this is the first section. It's recorded. I'm sure the trainees can listen to it again, because if you've not been exposed to it, you must listen to it slowly, and you can always ask me questions